Welcome everybody to the beginning of a new academic year, and we're pleased to have you all here. For those that don't know me, I'm John Mulder, and I'm the program director of the Trinity program, and part of this consortium of our 3 fellowship programs with other guests as well, helping to educate our fellows. This lecture will be followed by a case presentation. I know it wasn't in the invitation, but we will have a case presentation from one of our fellows immediately following from 8:30 to 9, which will be rotated amongst all the other fellows that are part of this consortium. And we'll talk more about that when we get into the case presentation mode. And those that don't need to be a part will have the opportunity to drop off. You've noted in the chat box that some folks have put their name and their email address in there. Now, if you wish to get CME credit for that, you do need to log in that way. It's not really logging in, but just giving us that information, and then our CME vendor then will log you as having attended this. When the invitations for these meetings come out, there is an attached PDF, and that's what you will fill out after the lecture to receive your CME credit. If you have any questions, you can contact me, and I can help you out with that. So see if I can actually start this lecture then. Okay. Okay, that's not what I wanted, but I guess it's going to work. Let's see if I can. If anyone was more technologically adept than I can tell me how to get out of this mode, and so just a full screen mode, that would be great.
Use slideshow. Are you on that?
At the top,
Upper left.
Upper left where it says use slideshow. That
Clock. Up above it.
oh, I see that. There we go. Okay, it might take a moment for it to catch up, but it's there we go. Now we can advance slides too. All right. Okay, sorry for the delays here, but we're going to start our series with a lecture about pain. And just as a disclaimer, so you understand what we're going to do today, we're going to be talking today about the philosophy of pain, and we're going to talk about approach to pain and thoughts about pain. Subsequent lectures will talk more specifically about the management and which drugs to use, and we've got specific lectures on things like buprenorphine and methadone and ketamine, and we've got on interventional and emergency and all these. So that's all going to be covered. I wouldn't say ad nauseum. We do a great job introducing people to pain, but I just thought I sometimes like to kind of reset the anchor in terms of why are we doing this in the first place, and what is we need to be thinking about as we approach our patients who are complaining about pain. So I like quotes. This one comes from Isaac Singer, in which he said, "Death I understand very well. It is suffering that I cannot understand." And then Ed Pellegrino is an ethicist who really, he made this comment: "Not to relieve pain optimally is tantamount to moral and legal malpractice." And one of the concerns I have, and you may have seen some of this also in the aftermath, not in the aftermath, because we're still in the midst of an opioid crisis. There seems to be a lot of opiophobia that goes on, and people become reluctant to take it as patients, families reluctant to administer it, nurses in the hospital reluctant to administer it, and often patients being reluctant to take it. And we see this in the pediatric as well as the adult population because we're concerned about addiction, and the concern is warranted, and we want to make sure that we're sensitive to those issues. But the consequence of that has been undertreatment of legitimate pain, where people with very severe pain are being compromised, and they're suffering as a result of physician reluctance to prescribe. I just talked with a friend the other day who was released from the hospital after fairly significant cancer surgery with some Norco, and he's having a lot of pain, and they just won't take the Norco as prescribed, and without any sort of creativity or trying to understand what's the nature of the pain. So we need to be very, very sensitive to, are we doing the right thing for our patient? I don't want people to be afraid of opioids. I want you to make sure you're learning how to use them appropriately and aggressively when necessary for the patients that are suffering. So more on that in the in the weeks ahead. But so our connection is making it, the slides move slow here. Andy Warhol had this, one of my favorite quotes, "It's not being dead that I'm afraid of, it's getting there." And we've done a pretty good job setting people up for an expectation of suffering, because people in the hospital have suffered. And the patients and not even just the patients, the physicians, the students, trainees, the nurses, the respiratory therapists, everybody sees this patient suffering, which leads people now to have a fear of advanced, serious, or terminal illness, because they have seen abject suffering in people that have suffered that. Our job is to try to remove that barrier. So, definition of pain: it's whatever the experiencing person says it is, existing whenever he or she says it does. So the patients, get to define for themselves what pain is and when it occurs. And all of us have experienced pain. I often tell people I grew up with 3 sisters. I know what pain is. I raised 8 teenagers. I really know what pain is. I've broken some ribs. I've had a couple thoracotomies. There's a lot of things that have gone on in my body and in my soul, which have manifested itself. And nobody can tell me when I was or wasn't in pain or how much pain I had. Only I know that. And so for we as clinicians, the key then is to make sure that what we are doing is assessing correctly, and then bringing out the right tools when we need it. As I would sometimes tell the students, can I treat the pain of a broken heart with morphine? And the answer is, of course I can. If I give someone who is suffering existentially a big enough dose of morphine, they'll be very, very comfortable. But it does absolutely nothing for them in terms of the underlying issue, and it really has solved no problem at all. So we need to be careful about that. Just one quick note on this. We all understand the pathways, but I just wanted to reiterate a couple of points about this. The pain sensation always going to start somewhere in the periphery or inside the body, and you've got these peripheral nerves that will send the signal through the spinal cord. You've got the dorsal root ganglion, connects to more neurons. They travel up the brainstem, thalamic nuclei, and from there to the corticosensory areas. And this ramifies more widely in the cortex as it is given meaning. And I think that's one of the more important things. The cerebral cortex has a very, very important role in terms of our being able to understand our own pain and our patients, kind of amplifying and characterizing that pain for them. Now, from a technical perspective, at every point along that pathway, including the cerebral cortex, there's an opportunity to regulate that, right? And we've got mu receptors, we've got the kappas, deltas. For all intents and purposes, we are talking about mu receptors are the ones that are pretty much targeted with the medications that we use. But I want to spend just a moment talking about the cerebral cortex with just a couple of examples of how that plays out. Many of you have been in the hospital when someone with pain has asked for their PRN medication. The nurse comes in, cleans off the stopper, puts the needle in, and slowly delivers that Dilaudid or morphine or whatever it is. And if you look at the countenance of the patient and you look at their face, you'll see, this just momentary relief that comes across their face. And the to me, the interesting part of that is that the drug is still in the tube. It's not even gotten into the body yet.
Mhm.
Okay. So the question, is the patient really getting pain relief? The answer is yes, because we have our endogenous opiates, the endorphins and enkephalins, which spring immediately in response to stimulus, which can be internal, external, or mediated by the central nervous system, by our cerebral cortex. If we think we're getting relief, there's a good chance we can get relief. It's why placebos are so effective. I had an uncle, my Uncle Bob, years ago. Decades ago, when he was 2 years old, suffered an encephalitis as a child, which wiped out a good chunk of his gray matter in the cerebral cortex, and he was left, functionally and verbally pretty much incapacitated throughout his whole adult life. One of the things that happened was he could not perceive pain, and that created some issues along the way. He had developed some colon cancer and a significant bowel obstruction. He never knew, even though his abdomen was extending significantly, because he had no pain. And of course, by the time he got into the hospital, it was a bit of a crisis, but that was managed okay. The more interesting one was, again, within my adult lifetime, I was serving as his DPOA, and he was struck by a car. He was walking along the road and struck by a car, and had bilateral open femoral fractures. He had bilateral hemopneumothoraces, and he had a depressed skull fracture. So I get a call from the ER doc who says, we got your uncle in here and he's in pretty bad shape. He says, but it's really weird. He had some language capacity, and he says, he's lying there like there's nothing wrong with him. And I said, yeah, that's Uncle Bob. He has no capacity to feel pain. They set his fractures and they put 2 chest tubes in with no anesthesia, no analgesia. Didn't need it because there's no pain. So he lost the capacity to interpret that physical injury as pain. And so to me, it's really, really fascinating. I had one unusual circumstance myself many years ago when I was trying to play Paul Bunyan. I'm not really, my wife doesn't let me around mechanical equipment and power tools and things like that for pretty good reason. But I was trying to manage a chainsaw, and my left foot was balancing the log, and I'm putting the chainsaw down just a few inches from my left foot, and it hits a knot and kicks. And so, but my force of my body was still going forward, so it kicked and came right back down just a few inches to the left of where the previous cut was. It went right across my forefoot, right at the metatarsal phalangeal joints. And in this, which I can still envision very slow motion, this tennis shoe that I was wearing shredding, and my white tube sock is shredding, and I'm seeing these bits of fiber and canvas going all over the place. And of course, my mind is, you just cut off your foot, what an idiot. And I threw the chainsaw down, and I'm palpitating, I'm tachycardic, I can feel myself sweating, breathing rapidly, and I drag my foot into the garage, and I sit down, I carefully peel off the shoe, which is shredded down to the sole. Didn't go through the sole, down to the sole though. And also this tube sock. And I thought, my fleeting thought was I thought there would have been more blood. But after I peeled everything off, I saw a fully intact foot. What happened, whether this was just the body just doing some sort of significant contraction or whatever, because when I put the shoe back on, I said, I don't know how it missed that forefoot, but it did. But the thing was interesting because as soon as I, thought my foot was cut off, I had this intense, searing, sharp pain that was just, I couldn't believe how much it hurt to cut off your foot. And then when I saw that I had an intact foot, my pain went away. Okay. So this was to me a personal example of how the cerebral cortical influence on pain. And I think we need to keep that in mind, because what our patients think and feel about pain is a large part of our being able to effectively manage it with or without drugs. And just other examples you might have seen, especially at a trainee level, one of the advantages you have is the time to spend a little more time, the opportunity to spend a little more time with our patients at the bedside. And you will find yourself time and time again walking into a room with an anxious patient who is appears to be in some moderate or more distress. And you sit down, your reassuring tones, your language, your opportunity to let them know that you're going to be, following this journey with them, that you're going to be looking at options and opportunities to alleviate their pain and their distress, whatever the symptoms are. And invariably, when you leave that room, their pain scores and their countenance are better. Okay. You haven't done anything other than be present, which we'll talk about this in future weeks. I believe that that's a very, very important therapeutic intervention in and of itself, just by being present and listening. And patients will respond to that. So patients' pain is better simply because you care. Sounds weird, but yes, morphine is good, but it's not the only thing that we can bring to the table. So we should never deny the potential influence of that. Okay, so I think that one of the questions that we might ask is, which is really, I think, a reasonable one, is what is the intention of what we're doing? Why do we treat pain in the first place? Well, one, we want to decrease the level of perceived pain. And the word perceived is very intentional here, because if the patients are not perceiving pain, such as my Uncle Bob, is there a reason that we need to put pain medications on board? Is there some physiologic reason that that pain medication in particular ought to be given to someone who maybe we think might have, but they don't perceive it? The other thing we want to do is to improve functionality. That's one of the things that is significantly limited by pain. And we want to improve mood. We want people to feel better. And so I think that if we think about those three things, pain, function, perceived pain, functionality, and mood, is why we treat it in the first place. Now, I want to just look at the issue of what's going on when someone presents with a complaint of pain. We all are well aware that pain is one of the most common motivators for people to seek medical care, and whether it be emergency or in the office. And I sort of split it up into these 6 sections that we can begin slotting that. Number one is what I would say garden variety nociceptive pain. It's mechanical, it's inflammatory, something's broken and it's going to hurt. Something is damaged, something is out of whack within the body, and that is resulting in pain. Could be inflammatory or mechanical. We're going to talk a little bit more about neuropathic pain, in which there's actually dysfunction of the nerve. It might be a global thing, a polyneuropathy. It might be a very specific thing like a disc problem in the back, a postherpetic neuralgia, a tic douloureux. My one issue that I have with neuropathic pain is for people to remember that we have a very, very vast nervous system throughout the body. There are nerves everywhere. And any time one is disrupted, it can cause neuropathic pain. So when you're taking the history on neuropathic pain, you want to look at the character of the pain. That's going to help to direct you to whether we've got neuropathic pain or not. It's not always, yes, it fits a dermatome, and so we know what that is. One of the more common examples of that is that we see in the elderly is a vertebral compression fracture. They compress that and they're damaging a lot of nerve ends within that bone. And people will tell you that it feels like there's someone's putting an ice pick through my back, is a common description of that. And yet, all too often in the ER, they're just giving them a straight opioid, usually Norco or sometimes Tramadol, and ignoring the fact that giving something that is more directed for neuropathic pain would in fact be much more effective in treating their pain. So just always have that on the radar. Is there a neuropathic component to that? Central pain is one that, again, is sometimes overlooked when there is actual central nervous system damage. We see it frequently after certain types of strokes. I've seen it after brain necrosis from radiation therapy. I've seen it after cord injury, and that can result in pain. And the characteristic of that is that it tends to be less focal, tends to be more generalized, and it can be diffuse. And that confounds the situation, because a lot of times we as physicians, if we can't pinpoint a source of pain, we start thinking, is this patient really having pain? Are they malingering? Is this a psychogenic pain or something of that nature? So again, a good history in terms of, could there be some element of central pain. We also see that certain types of chronic pain syndromes, fibromyalgia, and now a lot of chronic abdominal pains have a neuropathic component. So always just have it in the back of your mind, could this be something so? Psychospiritual pain is, when we've all seen circumstances which depression, anxiety in someone will escalate their pain threshold, or probably decrease their pain threshold and escalate their pain experience. And it's a two-way street. The more pain you have, the more depressed you are, and the more anxious, depressed you are, then the more pain you're going to have. So is there some element of mental illness or psychological or emotional issues going on that can be attributed to that? I once in my family medicine days walked into a room, and one of my patients who I knew quite well, it was sitting in the corner, slumped into the chair. And she says, "Oh, Dr. Mulder," she said, "my head hurts, my back hurts, my heart hurts." And in those 9 words, she was able to make the connection between the heartache that she was experiencing with a lot of distress in life. And she knew that's why her back hurt and why her head hurt. Because when she didn't have that distress, they didn't hurt. So pain was her manifestation of that. And again, you could give her pain relievers, but that doesn't really address the issue of how can we help her navigate and manage the distress in life. People also have spiritual struggles that they relate in terms of pain. Again, that could be the relational issues we mentioned earlier, but it can be disenfranchised from God. It can be some people feel that they've done bad things, and as a result of that, they're warranted. The pain is their punishment for having done sinful things within their spiritual context. And so spiritual pain is a real thing as well. Again, the importance of good history. Aberrant behaviors is a reason that people will use the word pain. Sometimes it's a business transaction. They sell, and that's, they need to get drugs to be able to sell. And they know that if they complain about pain, perhaps a compassionate, sensitive doctor will give them pain medications to help with their, in quotes, pain. A lot of times there's a secondary gain issue. And these sometimes are the more challenging ones, where patients tend to be sickly. They tend to be on an illness side of the curve, in which there always seems to be something wrong. And workups maybe don't often reveal underlying medical conditions or issues, and yet they tend to always have a reason to be in the doctor's office. Sometimes that's because they don't have others in their life that care about them. That may be, for some people, that's their social structure. And if you relieve something, then you've taken away one of their very, very important lifelines. And so a lot of times it's like whack-a-mole, something else will pop up that gives them a reason to come to the doctor. So these secondary gain issues can be very, very challenging as well. Again, we need to avoid the trap of thinking that if they're complaining of pain, then morphine is the answer. And then people will complain about pain if they are suffering substance use disorder. And a lot of times that pain is real, but a lot of times they have been trapped into a substance use vortex that becomes very, very difficult. We'll have very specific lectures on that as our year rolls on, so we're not going to talk too much about addiction today. But I just want you to be aware that these are the types of categories that we want to be thinking of when someone is entering our office complaining of pain. So part of the key here is the evaluation of the patient. And how are we going to do that? Now, you all know how to take a great history and physical. And so that's really not the issue. I just wanted to emphasize this, because still in this day, I will get calls from hospice nurses. I will get calls from other physicians who are having challenging pain issues that they're wanting a little bit more input on. And say I've got Mr. Smith, and he's 67 years old and has lung cancer, and his pain is 8 out of 10. and we've got them on some, on a fentanyl patch and on some short-acting oxycodone, and I don't know what else to do. Well, I'll probably start with, tell me about his pain, because also they said he has pain. Well, but what does that mean? And so just to remember the usual things is focal, generalized onset and course, the exacerbating leading factors, what's helped, what hasn't helped, previous treatments, previous diagnostics, associated symptoms. All these things are very, very important in terms of sifting through where is this pain coming from, and then how can we best do it. Functional impairments, I'm going to talk more about that in a bit, but that to me is a really, really important aspect of trying to assess pain. What's their support system? Again, that gets to the issue of secondary gain issues. What kind of a system do they have in place? Psychopathology, we just talked a bit about that. A family history of pain syndromes, I tend to include in my history as well. Not because we are aware of any genetic link between certain pain syndromes, but I will tell you that behaviors are learned within families. We all know that. And habits are learned within families. And if there is a family and the children growing up observe that mom or dad or both have a tendency to reach to the medicine cabinet every time there's a little something going on, or they as a child, every time there's a minor injury or ache, that they reach for a medicine bottle of some sort, then we might say, oh, okay, this is a family that that has a tendency to focus on the ailment, focus on the pain, and look for chemical strategies to relieve that. If you've got something like going on in the family, then this is what patients may expect. So understanding what's going on in the family can be very, very helpful. The last two bullets here is, the opioid naive or tolerant patient and pre-admit pain regimen. I can't tell you how many people I've had that we've had well controlled on pain. They come into the hospital, for something unrelated, and their pain regimen is jumbled. Medicines are taken away, others are added. Someone's going to say, well, this is how I do that. And so we need to be respectful of what has worked and why, and how they got there in the first place. Now, there's also people that are going to come in, you'll be consulted with them on them, and you look at that and say, this pain regimen makes no sense. They're on 4 different opioids, and their pain doesn't even seem to be one that should be opioid sensitive. And so you do have the opportunity to help to correct those sorts of things when you see them. But we want to make sure that we are very clear about their opioid tolerance and their naivety when we start a regimen, and also what have they taken in the past and what has worked. Okay, I wanted to spend just a moment going through those 6 categories just to pick up some of the pieces I may not have mentioned. The nociceptive pain, again, these are the garden variety types of pains that we will see day in and day out in patients that have all sorts of medical and skeletal issues. The nociceptive pain, I think typically we're going to see that localized to the area of pathology. Typically, sensory exam is normal. The pain is an appropriate response in the body. This is what's going on disease-wise or injury-wise, and so we would anticipate pain to be a part of that. And so if you can correct the underlying problem, obviously that's going to be ideal. Sometimes in the case of cancer, for example, that's going to take a while, and it may not be possible to completely correct it, but we can address that. We're going to talk more in a future lecture about interventional pain, but regional anesthesia is something that we don't think about enough in terms of how do we, can we hit a plexus, can we block a nerve, because that can be very, very effective. A lot of times we're just falling all over ourselves, giving drugs over drugs over drugs, when a simple nerve block might be able to take care of the whole issue. So we don't want to forget that. May consider steroids. Typically steroids within our realm certainly can be helpful in paying crises. They can be useful short term. If we're talking about hospice patients with a very limited life expectancy, we can pretty much use them with impunity and not worry about the long-term side effects, because our patients have very short prognoses. In the palliative realm, when patients may live quite some time, then we have to be very careful about how we're using the steroids in that circumstance. And we can still look at nonsteroidals and acetaminophen as first-line drugs. I just want to take a moment to emphasize the importance and value of acetaminophen. I will tell you that when we talk about the cortical influence on pain, we as a medical care system have done a very, very good job influencing patients that Tylenol is not that effective as a pain reliever. It's cheap, it's over the counter. We always give a first line and tell people if it doesn't work, we'll get to something, we'll get to the good stuff. Okay. We need to change that narrative a bit. And when we prescribe Tylenol, we can tell patients, I got to tell you, this is an excellent analgesic. We know exactly why it works, how it works, and it's going to do a really, really fine job in beginning or even completely resolving your pain. I've experienced that, firsthand. I've, been in the hospital and had, some issues that would produce significant pain issues. And I've controlled it with extra strength Tylenol, and I have a relatively low pain tolerance. I mean, I have pain in my foot without even injuring it. So that's my pain tolerance level. A couple of things that I've seen in the clinic that have really influenced me on this issue also are the patients that have come in on Norco. They've been on Norco and a doc switched them over to oxycodone, same dose. They're on Norco 5, now they're on oxycodone 5, and they come into me and said, I need my Norco back because that oxycodone doesn't work at all. Well, how cool is that? And I just draw it out for them. I say, here's what Norco is. It's hydrocodone plus acetaminophen, as opposed to straight oxycodone. Oxycodone, hydrocodone, first cousins, same church, different pew. They work exactly the same way on the same receptors. And the fact that the oxy isn't working and the Norco doesn't, I mean the other way around, that the oxy doesn't work, but when the Norco did, suggests that the acetaminophen is the effective pain reliever for you. How cool is that? So we want to make sure that we are influencing people to understand and believe that that will be an effective pain reliever, not as just a throwaway that we're going to, we have to go through that hurdle before we get you to the good stuff. It is good stuff. And it can be as a primary or as an adjunct. And of course, with nociceptive pain, we'll consider opioids if need be. So I already talked a bit about neuropathic pain, just in terms of recognizing it. And this is just a very short list of the types of things. A couple of things I wanted to point out here is phantom pain, burn pain, scar pain, and irritable bowel syndrome and chronic pancreatitis. A lot of times those are not necessarily immediately recognized as having neuropathic components, but they do have neuropathic components and can be helped with the neuropathic plan of care. So again, with neuropathic pain, just as with the nociceptive pain, it is localized to the area of pathology. But sometimes that area of pathology is somewhat challenging to understand. Sensory exam typically is abnormal in neuropathic pain. So you might want to think about temperature, sensation, pinprick, adding those to your armamentarium of exams, which I think in neurologic exams, some people don't necessarily include those automatically. And I just lost my host privilege there. Hang on just a second.
John Mulder is the host now.
Okay. Let me see if I can share my screen again. Take it just a moment for this to pop up and we'll get back on there. I'll keep talking while the slides are ready to pop, or we're waiting to populate. because you won't know a lot of this anyway. In terms of neuropathic pain, again, there can be loss of sensation. There can be some allodynia paresthesias, which we'll talk about a little bit more in the central pain slide. When you have neuropathic pain, especially peripheral neuropathies, search for correctable cause. It might be diabetes, it might be multiple myeloma, B12 deficiency, alcoholism, trauma. Those sorts of things can contribute to neuropathic pain as well. In terms of interventions, we have the tricyclic antidepressants, which have been the standard for this for years. They've sort of been replaced by the anti-epileptic drugs, specifically the gabapentinoids. SNRIs are becoming more popular for that. Local anesthetics can work, whether that be lidocaine patches, for example, compounded creams. We're going to talk more about ketamine in later lectures, which I think is a great option for peripheral neuropathies. Neuromodulation, which we use TENS units and other sorts of electrical stimulation. And again, injections, pulse radiofrequency ablation of peripheral nerves, sympathetic blockades. I would say in general, with neuropathic pain, it's good to avoid opioids, especially as first line. They tend to be less effective. I wouldn't say they're completely ineffective because pain pathways, there's still going to be some mu opioid influence, but because there is such significant because there's such significant issues within the nerve itself, then your mu opioid receptor agonists are not going to be nearly as effective at controlling neuropathic pain. Central pain in a similar way, again, as mentioned, that can come as a result of any sort of central nervous system trauma. Opioid-induced hyperalgesia is a type of central pain as well. But again, non-localized sensory exam is abnormal. It is hallmarked by this hyperesthesia, paresthesias, or allodynia, which is present. And you always want to test temperature, sensation, pinprick, vibratory in this. Search for correctable cause. I put psych and social factors here because they can be very significantly influential in central pain syndrome. Again, it is resulting from central nervous system damage, but it can be influenced by a lot of different. Every once in a while, I'll go to some of my old textbooks, and I have a Harrison's from when I was in medical school. And it was a long time ago that this was copyrighted 50 years ago, the Harrison that I have in my shelf at home. And I was curious what they had to say about central pain, because it changes and evolves in terms of how we view that and how we can manage it. There was one paragraph in all Harrison's about central pain. And it really said that, we really can't treat this. So put them in a dark room and sedate them. That's I'm going to still consider a contemporary medical textbook. But that's how challenging it can be. But there are strategies, and just my spoiler alert is ketamine. Love ketamine for central pain syndrome. Again, avoid opioids. They don't necessarily have much value in this. The psychospiritual pain, again, this pain may be vague and non-localized, so that when you're dealing with this, is this a central pain or is it a psychospiritual pain? You're going to want to dissect that. It could be resurrection of a previous pain or exaggeration of a minor insult. People that had an auto accident 14 years ago and they're still having some residual pain, even though we can't identify any specific structural or tissue abnormality that would suggest that pain should still be there. It may be a result of some PTSD or some other sorts of result and reaction to something previous that is resulting in this pain. It's good to take a spiritual history. Evaluate for depression, anxiety, consider it, again, meritorious or redemptive suffering angle. That could be an issue that patients are having as well. Good to get your social workers, your psychiatrists, psychologists, chaplaincy, other spiritual advisors involved in the care of the patient. And a lot of times it's really clear that when patients, I think that there's some psychospiritual issue, it's never, I think it's all in your head and I think you're crazy. It's really from the perspective that we know the pain that you have, the type of pain you have, has a significant impact on our happiness, our joy. It has an impact on our soul and our spirit, and all is in fact impacted by pain. And so we want to make sure that you are staying as balanced, as grounded, and as focused as possible as we're working through this pain issue. And so working on the psychology as well as on the physiology and the pharmacology is really, really important to this process. And people will grasp that concept. And so I think that we need to make sure that when we're dealing with the potential of psychospiritual pain, that they understand that that's what we're looking at, and this is why we're bringing these people in. But that doesn't supplant other ways that we're going to be looking at that. Analgesics then in psychospiritual pain are adjuncts only and must be related to some underlying pathology. And again, very, very important to avoid opioids. So I've mentioned aberrant behaviors is another reason that people complain of pain. I had a patient years ago who had a hepatocellular carcinoma. It was a relatively large, about 3-4 centimeters, slowly growing. It had been resistant to treatment. This was many years ago, so the treatment options were more limited back then. But had significant pain from the capsular swelling. Her oncologist had put her on a low dose of OxyContin. She came to see me. And so taking the history, yep, that seemed to be effective, but she was still having a meaningful pain. So I titrated it, seemed a little bit better, one more titration, and she says, I think we've got it. And from that time on, she was the perfect model patient. She came in once a month, just as she was supposed to, never was short on her prescription, never called in for a refill early. She was delightful, pleasant. After about 1.5 years, she failed to show for a visit. My nurse was very concerned because we had all, she'd become part of our, our little community, one of our success stories. And after a couple, 3 days, we knew she was going to be running out. And so my nurse started trying to track her down. And what she had was a contact from a sister, called the sister. And she said, oh, you must not have heard. Heard what? Usually those, what we get is, oh, she died. But this one is, oh, she's in jail. She was selling her oxy to an undercover police officer. So what she had learned was, and she had real disease, real pain that had real response to oxy. She also recognized that how she presented herself could result in a large prescription of the medication. So she took exactly what she needed to relieve the pain, and she sold the rest. So any of the the tricks and the tools that we often use, for example, drug screening, yep, she's going to be positive for the oxy, nothing else. That's exactly what you'd want to see in that particular circumstance. So the point is that you're going to get snookered somewhere along the line. You can do everything exactly right, and people are going to try to take advantage. And I replayed that time and time again, say, what could I have done different? How should I manage that differently? The dose was not a significantly large dose, not out of bounds for what you would expect for that type of a clinical situation. So I just don't want you to beat yourself up like I have for 25 years on that particular case, because it will happen. And the key is you do the right thing and you document well and make sure you're doing the analysis. And I think that when we start thinking about, is this aberrant behavior influencing my prescription habits? It gets back to this issue. Is this pain what I would expect for this type of a disease, given the cortical influences that we talked about? And are they responding the way that they should with, to the medication? And if they're not responding the way that they should, then that you ask yourself, well, why? Why are they not doing that? So the issues that might trigger us to think more about the aberrant behaviors, you're going to take this thorough history of previous medications, and including what have you taken over the last 3-4 days, 5 days, last week. We have the opportunity to, and it's required by law that we do a MAPS on patients. We initiate and change prescriptions. You do the urine drug screen for illicit substances. And just as a caveat, I don't use the UDSs for the purpose of discharging someone from the practice, but just to find out what else is going on in their life that we might need to address and help to modify so that they will be effectively managed. Do they have a history of drug alcohol use by the records or directly from the patient? With respect to addiction, again, we'll talk more detail about that later, but it really relates to the loss of control, the use despite harm, and these ruminating thoughts. So, Jason.
Just a quick thought, but it'll be very interesting thing. We've got 2 ER physicians in the room, right? PM and R, and then we've got family med over here. And I wonder how our training and the patient population we see in the context, how that might impact them. So not for now, but as we evolve through this, be curious to see how that all comes together.
Yeah. I want to spend just a moment talking about pain scales. That's a great point, Jay, though. When we think about that, because, and that gets into implicit bias.
Oh, of course.
And it's all about bias in terms of what we have experienced as physicians.
Mhm.
And in the ER, there's a much different population that is coming in.
Yeah, time, relationship, thus context, and the less you have, the more on guard you must be. As doing rehab, and you maybe have a relationship with someone built over years. So how we come at this from our practice certainly will impact it.
So I'm not going to talk about these. I just want you to be aware that there are dozens and dozens of pain scales out there that you can use as an adjunct to assessing someone's pain. Again, the patient pain is what the patient experiencing it says it is whenever he or she says it exists. So we as docs like numbers, we like scales, we like some way to validate and make objective what someone is telling us. Very, very difficult with pain, but here are just some examples of numerical rating scales, what we all use, 1 through 10, but there are visual analog scales and on and on and on. The 1 to 10 scales, the FACES scales, the McGill pain, pediatric pain scales. I'm only listing this so that you are aware of all the varieties of ways that pain can be assessed. So the 1 to 10 scale is one that we're most familiar with. We're well familiar with its shortcomings. Why? Because, when we tell patients 0 is no pain and 10 is the worst pain that you can imagine, and especially those in the ER see it all the time, 15, 100, it's 1,000. A friend of mine who is an ER doc who tends to run on the somewhat caustic, cynical, sarcastic side of attitude, has been known to tell his patients when they give him a number above 10, oh, so if I lit you on fire right now, you wouldn't hurt any more than you hurt right now. I think it's a little extreme, but his point is well taken. People don't understand how to interpret that. And having, again, in my own medical journey, when someone says, well, how would you rate your pain today? It hurts. I can't always put a number on it. Where the scale, I think, finds its greatest value is in monitoring the effectiveness of a regimen. It was 7, now it's 4. Sounds like we're on the right track. So I think it has some utility there. Patients will over-report, they will under-report. It's always a 6, it's always a 6. It never changes no matter what we do. And so for some patients, you'll figure out fairly quickly, is this a rational scale or not? I had at the very, I just the other words on this page, on this slide, people will use language other than pain. Is it comfortable or uncomfortable? No, I have no pain, but it's really uncomfortable. Okay, on a scale from 0 to 10, where, 10 is as most uncomfortable as you can be, so we have to sometimes use their language in there. Is it tolerable or intolerable? Is it continuous, episodic, incidental? And those are exactly what they mean. Episodic is, it is most related to cancer breakthrough pain when it's just, it occurs and we don't necessarily have any predictability into why or when. Incidental is pain that's incidental to something. They always have pain when we're doing the dressing change. They always have pain when we turn them in the bed. Those are incidental pains. Incidental pains, we might be able to develop some element of strategy for addressing. The bolded at the bottom, functional impact, I think, is one of the most important things that we need to be looking at. And that is, what can you no longer do because of your pain? What is preventing you from doing? I went into the room of a 27-year-old young woman, asked to help with her pain issues. I looked at the chart, which was voluminous. In and out, I think the previous 12 months, she had had 20 interactions just within that 12-month period of time, some resulting in hospitalizations, some just ER visits. But she had been, poked and prodded, scoped and scanned up the wazoo, including a laparoscopy to look for endometriosis, or it was a lower abdominal pelvic pain. And nothing was found. She'd had colonoscopy, upper endoscopy, she'd had CT scans, she'd had MRIs, and nothing objective was ever shown that was consistent with her pain. Nothing cyclic about it. And so I walked in the room and she was standing up. She was actually across the room getting something out of her closet. And I walked in, knocked on the door, I walked in, and she smiled and says, "Oh, hi." And I says, "Hi, I'm Dr. Mulder. I'm here to help with your pain." "Oh, great." And she literally hops across the room, jumps into bed, pulls up the bedclothes. "I'm so glad you're here," smile on her face. And I said, "Yeah, the pain is really, really bad. It's like a 9 out of 10. And I thought about it, and probably the only time I've ever told someone I don't believe them, I said, I find that hard to reconcile that it's a 9 out of 10. 10 being the worst pain you can imagine. So what, you don't believe me? Is it because I'm not screaming and writhing? And then she flipped a switch and put that show on for me. How she could writhe and scream and moan. And she said, "So if I were doing that, then you'd believe we're a 9? I said, "Well, yeah, actually. But if we're truly a 9, you wouldn't be able to turn it on and off. I believe you have pain. I believe your pain is really, really severe. But I think our job is to try to get to the bottom of this." And she says, "It's pretty simple. Give me my Dilaudid and we'll be just fine." My question to her was, do you really want the Dilaudid or do you want to be done with your pain? Well, the Dilaudid is the only thing that takes the pain away. But if we can figure out where this pain is coming from and eliminating that, then we're onto something. Because I'm thinking you don't want to necessarily live your life in the hospital 20 times in 12 months. "Well, they won't give me Dilaudid to go home." I said, "Well, there may be a reason for that. Let's talk more about other reasons that you might be experiencing this pain." As you all know, that young women with that history, you look for some element of trauma, abuse, something of that could have traumatized them at even a very young age. It was really clear after beginning to probe that we were not going there. She had no desire to have a conversation about that. And so I was fired within about an hour and a half, and no idea. But it again brings up, the people focusing on the pain scale. So rather than a 1 to 10, if you need to chart a number, you get the number. But this is the question I ask: are you comfortable with your patient, with your current pain control? That's a yes or no answer. It doesn't matter what the number is. If someone's comfortable, again, one of our main objectives in treating pain is to lower the perceived pain level. So if they're comfortable with it, I don't know that I need to do much. If they're not comfortable with it, it requires some element of attention. It may not be pharmacologic, but it needs some attention if they're not comfortable with their current pain control. And then the second question has to do with the function. What are you not able to do because of your pain? So I want to take just a moment. I see we're just a little bit over time, and I'm going to take advantage of the fact that we had some tech issues keeping us, and just again talking a little bit more about some philosophic issues about the pain management. Some of these seem really self-evident and obvious, but it often is not abided by. You want to select the appropriate analgesic drug. There are doctors that will simply use the same drug every time, no matter what. There are different drugs for different conditions. As we talked about, there are different types of pain that might require an anti-inflammatory, might require a neuropathic medication. In the case of opioids, I like to consider the concept of monotherapy. If you're going to be using a long-acting morphine, use a short-acting morphine. I think that makes a little more sense, makes it easier for conversions. You don't have to, but it makes sense to me. Prescribe the appropriate dose. That has to do with the patient's underlying issues, their age, conditions, other medications they're on, and previous history with that. Administer the drug by the appropriate dose. I would say that PO is preferred, except in a crisis in which you can use some sort of parenteral, sub-Q or IV. There's an awful lot of folks that someone comes in with pain, they put a patch on them. Well, that's not necessarily the appropriate thing. First of all, if they can take it orally, that's really that's advised. Also, for acute pain, the patch doesn't necessarily work. It takes too long to get into the system. I was asked to serve as an expert witness on a case. Patient had some cancer-related pain and had been to the oncologist office on a Thursday. On a Friday, still in a lot of, and the oncologist gave them a fentanyl patch, 25 mic fentanyl patch. Friday, they're in pain. They couldn't be seen in the oncology office. They sent to the ER. So the ER doubled the patch, put them on 50. And that was in the morning. Friday evening, they came back because they were still in a lot of pain. And so the ER doc started them on methadone. Saturday went back and the methadone was tripled in dose. So within 48 hours, this patient was placed on 2 different patches, some dose patches, and different doses of methadone, all of which, of course, have a very prolonged half-life. The patient was dead on Monday. They asked me if I could serve as a defense witness for the hospital. And I reviewed the charts and I said, I don't think I can. I don't know that you're going to like my answer. But that sort of using drugs like that, using drugs that we typically would use for long-acting management of controlled pain, and using them in an acute sense and with no respect for the half-life, that just shows some element of misunderstanding of these drugs. And if they don't understand, they shouldn't be prescribing. So schedule the appropriate dosing interval. I often will see folks in the hospital and they're given, IV morphine or fentanyl or Dilaudid, Q 4 hours, Q 6 hours, Q 8 hours. And again, with the students, I will say, okay, what's the time to peak effect of IV? I mean, you're giving an IV because you're trying to treat acute pain. Time to peak effect typically is around, they kick in 15 minutes, peak effect somewhere between 45 and 60 minutes, and then the effect starts to taper off. So what are you going to do between hour 1 and hour 4? Or they will be using PRN long acting. You give them, some MS-Contin and take it twice a day as needed. No, that's not how you manage those. So you want to make sure you're using the right dosage interval. You want to prevent persistent pain, relieve breakthrough pain. You want to titrate the dose aggressively, appropriately. Prevent, anticipate, manage side effects. We'll be talking about that later on in a subsequent lecture. You may want to try sequential trials of opioid analgesics. If something is not working, it's okay to switch to a different one. With what we're learning about pharmacogenomics, there are some people that respond to certain opioids better than others. Unfortunately, we can't diagnose that without doing a full genomic profile. Use appropriate co-analgesic drugs, particularly in the case of neuropathic pain. And again, as we kind of alluded earlier, consider current opioid exposure. I would say that pharmacologic treatment is the cornerstone of cancer pain management, although as we'll learn later, interventional options can be considered. It must be individualized. We just can't do all size fits, one size fits all. Should be simple, non-invasive as possible. I think that just makes sense for the ease of the patient and as well as for effectiveness. We'll learn later, equianalgesic tables must be used. You can get them on your phone. You can just call one of your colleagues, just call the pharmacist. And always keep in mind, although addiction, substance use disorder is an issue, it actually doesn't happen that often when we're monitored appropriately. We know that 80% of people with substance use disorder had their first exposure to a prescription analgesic, which may or may not have been appropriately prescribed for them. But we know that they can trigger them. Keeping in mind, it doesn't mean that 80% of people that get on these medications are going to have some problem. But because of the concerns and the challenges with addiction, we want to make sure that when we're giving it, we know what we're giving, how we're giving it, how long we're going to be giving it for, and how we're going to be tapering that when we're done with that medication. Prescribe the appropriate dose. Again, that's based on pain intensity, current analgesic therapy. There is no one optimal dose. There is no one maximal dose, quite frankly. There are doses that people feel more or less comfortable with, but the appropriate dose is pain relief throughout the interval without unmanageable side effects. And so we can be very judicious about continuing to titrate opioids as long as we're managing the side effects okay. Our goal, we want to prevent pain recurrence, minimize the number of daily doses. When someone has a pain that we expect is going to continue, such as cancer pain, this is one that's going to be with them for probably a while, especially if you don't have a curable cancer. So we anticipate the pain. We put them on long-acting, we put them on scheduled meds with the breakthrough, breakthrough doses to deal with the episodic pain. And so the dosing interval depends on opioid and the route, how patients are responding to that, and any end of dose failure that we're seeing. So I'm going to stop there.